Welcome to Tennessee Court Talk. I'm your host, Barbara Peck. This episode is a collaboration with the Tennessee Judicial Opioid Initiative and is intended for all audiences. Today we are discussing drug trends across Tennessee, and we have two special guests with us. Tommy Farmer is a special agent in charge with the Tennessee Bureau of Investigation and is the state director of the Tennessee Dangerous Drugs Task Force. He has over 30 years of experience in law enforcement, 20 of which were in the field of drug enforcement. Our second guest is Robert Pack. He is a professor of community and behavioral health and associate dean for academic affairs in the College of Public Health at East Tennessee State University. He is also the executive director of the ETSU Center for Prescription Drug Abuse Prevention and Treatment and the co-director of the Opioids Research Consortium of Central Appalachia. Welcome to you both.
It's great to be here.
Thank you very much.
So, in early July, the CDC released new overdose-related fatality statistics for 2018. And for the first time in 25 years, the numbers were down nationally with 5.1% less deaths in 2018 than in 2017. Unfortunately, that pattern did not hold true for Tennessee, where overdose deaths again set a record at 1,837, which is a 3% increase from 2017. Tommy, what was your first reaction when you saw those new statistics?
A couple of different things. I wasn't really surprised to see the numbers go up just a little bit more. I was surprised to see the numbers around the country, as compared to other states, them go down. I was anticipating a slight climb. We were hoping that we would plateau off, and if there was any increase, it would be a slight increase. And so we did see a slight increase. There's no question that our belief is related to the transition to illicit drugs. No doubt that it has to do with fentanyl and heroin and the availability of those drugs. No doubt about that.
Rob, what was your first thoughts when you saw the new statistics?
Well, like Tommy, I was pleased to see the change nationally. We've known for over a year now that the overdose epidemic has been increasing exponentially since the mid-'90s. And so we actually have known that if we don't do something dramatically different nationally, that we're going to see several 100,000 people dying over the next 5 years. And so I was real pleased to see that, the national change, and particularly impressed by states with very high overdose death rates like Ohio and West Virginia make significant improvements. And so those are good things. Now in Tennessee, like Tommy, I didn't expect to necessarily see a dramatic decrease. We have incremental gains and improvements in a number of things. We need to do a number of other things in order to improve more.
So let's look a little deeper at Tennessee. So where are we seeing improvements and progress?
Well, I think one of them is in improvements relative to access to buprenorphine and good quality medication-assisted treatment. And that I put the good quality MAT in front of that, but I think it's imperative that we recognize that there are good providers for Suboxone and buprenorphine products that are out there. We need to begin to do even more to improve quality overall, because there are a number of less good and in some cases even poor quality Suboxone providers, and we have to do better with those guys.
Well, I think we're definitely seeing progress in the reporting. Collectively comprehensive reporting, and I think, unfortunately, an unintended consequences to improving our abilities to collect information, analyze information from multiple sources. I think it has a tendency that it could be represented in some of those numbers that increase. We're doing a better job. Unfortunately, it also shows us that before, we've said for a long time that the numbers are grossly underreported. There's a lot more out there than what we're actually seeing. I do believe that this number is indicating that we're doing a better job getting more accurate information and analyzing the data out there. Other areas, I would echo exactly what Dr. Peck said. We are doing better at educating others, to include the courts. We're getting more access to treatment. Law enforcement is better educated. Law enforcement is having the access or being able to direct someone and those families to resources. to treatment resources, to options out there. That is a huge asset for law enforcement, because I can tell you they've been out there for a long time faced with those questions, and even to the point where the family's literally begging law enforcement to arrest the person, that was going to be the only option that they would have that would save that person's life. We didn't get to this position overnight. In Tennessee or in the United States, we didn't get here overnight. We're not going to get out of this thing overnight.
So you mentioned a little bit about the shift from prescription drugs to illicit drugs. So where are we on the fight with prescription drugs?
Well, I'll address it first, I guess. But Tommy, you're going to have some really good data on this as well. But our peak opioids and peak prescribed opioids was really in the 2013 range. And we've been coming down with respect to prescribed and dispensed opioids from the regular sort of traditional method of getting prescriptions. And as that began to decrease, the demand was still there, and that began to drive heroin access, and then the market for heroin increased, and then basically fentanyl adulterated heroin and now fentanyl adulterated other drugs like stimulants are more prominent on the market. And so there's been basically prescription drug decline and an illicit drug incline. And so unfortunately that's also being driven out of our larger cities where there's more potential demand for the dealers.
Where are you making progress in?
We're definitely making progress with the diversion, the decline of prescriptions and diversion. Those numbers are really good. And I think some of the tools that we've implemented in our state, from the chronic pain guidelines to the controlled substance monitoring database to education, and I think it's hugely important. We're giving and providing those providers the opportunity, the ability to look at their patient and to better treat their patient. I mean, at the end of the day, some, I think in the beginning of this, looked at as almost as an insult that we're challenging them. No, we're not challenging their ability to treat their patient. What we're doing is providing them more tools to the toolbox to be able to treat their patients better. And I think another huge part of this is, I don't think we took a knee-jerk approach. I think we've done this better than a lot have done because we didn't go all the way at one time. You can shut this thing out. We could pass legislation tomorrow if we needed to and say we're going to cut prescription diversion or the amount of pharmaceuticals that can be prescribed by 50% tomorrow. Well, just because we cut that off by 50% tomorrow does not necessarily mean that we reduce the demand or we reduce the need by 50% overnight. So when you do that, you always use the analogy of a balloon. You can squeeze a balloon. The balloon has two options. It will either pop, bust, or it's going to push out one of the other areas. And so we knew and expecting going in, I think Doc would agree with me, we knew going into this that as we pushed forward and made progress and implemented tools to address the problem, we were going to see a transition or an increase in illicit drug use. What we all tried to do in a balanced approach is before we start pushing fast or pick up the pace, we wanted to do it at a pace that was reasonable, that we didn't push too fast, too hard, and that we were implementing back support with treatment options, with enforcement, and all of these things comprehensively moving forward so that we did not derail this train. We've got the ship in the right direction. It sometimes takes a long time to get it in the right direction. We got it in the right direction. We have to keep it going in the right direction, because if this thing starts to go off course, as we all know, it's very difficult to get it righted again.
Mm-hmm. So I want to add one point. We reached peak opioids around the time, 2013, but we're still in the top 5 in the country for opioids. And at one point we were number 1 or 2 for toggling back and forth with Alabama for a number of years. And I think it's going to take a while before we get that down to, the 50th percentile or less. But I just need to point out that we're still in an era of significant prescribing for prescription opioids that is different than most other states.
So let's talk about the rise of illicit drugs now. So what is fentanyl and how is it being cut with heroin and stimulants, and where is it coming from?
The majority of the fentanyl, two primary, it's coming from a lot of different ways, but commercial coming into the country predominantly by commercial carriers originating either out of China or out of Mexico. And obviously other areas it can be routed anywhere around the world into the United States. Where it's uniquely different is that, again, the physical characteristics of fentanyl make it very dangerous and really present not only law enforcement, first responders, but providers and everyone else. It presents some very big challenges and requires a lot of protective equipment. But also from an enforcement standpoint, we're no longer, we have something that is very, very powerful at very small amounts, and the potency of this. And so that enables smaller or packages of smaller amounts, but have the potency that you would be looking for. It's easier for me to detect coming across or to intercept a package of 10, 100, 500 kilograms of something. It increases our abilities to detect those and to enforce those, as opposed to the equivalence in terms of potency or of fentanyl may only be a couple of sugar packs or a couple of ounces of something that could easily be secreted and hidden and transported a lot differently.
So is the heroin already cut with fentanyl when it arrives in Tennessee, or is it being mixed in Tennessee?
That's all different ways, every one of those. It's easier, typically we will see the fentanyl getting smuggled into the United States, into Tennessee, and then once it's in Tennessee, it's used as an adulterant to different drugs. We'll see them in pill presses. We've had about 15 pill milling operations. We've had operations where they are cutting it into heroin or cutting it into methamphetamine or cutting it into cocaine, adding it to just about anything because, again, it doesn't take much of that. And the end result, the person's looking for a high, not necessarily and I hate to use this the wrong way, the quality of a high. They're just looking for a high. If they're getting high off of it, it's meeting their needs, their expectations for a high, then it's working for them. Depending on the source, if it's Mexican, we will see a lot of that already cut into the heroin that's being smuggled across the border. Different ways, pill forms, we see it both ways coming in, already cut into the products, or it's mixed into the products once it gets here.
So does the buyer necessarily know that the fentanyl's cut in? Are you asking for that particularly, or you're just asking for heroin?
Both ways. Again, it's an unintended consequence. I was approached when we had major operations. We had a series of overdoses in a couple of different cities. And so when we were talking about the problems associated with fentanyl, and we're saying you can't control, there's no quality control here. It's not a matter of if, it's a matter of when you're going to overdose yourself, because the optimum high, when you're getting high off of this very small amount but very potent amount, is also about the same time that you're going into an overdose. And so where it triggers an overdose versus where it triggers the optimal high is so close to each other. And it's reckless behavior. It's a matter of if you're going to overtime. Why would someone sell a drug knowing or that there's a higher potential that their customer would overdose and die? And that's losing a customer. And the simplest answer I can see, irrational people do not make rational decisions. What they are seeking and what they're looking for, and they literally, if they are wanting the strongest drug that they can get, and they view others that did overdose as they couldn't handle it. They were weak. They couldn't handle the drug. I can do a better job. And so when we've had those episodes where we've made public service announcements saying we've got fake Percocets, counterfeit Percocets that have high amounts of fentanyl, and we've had 19 overdoses, don't do the Percocets. The calls to that phone increased. The demand for that drug that overdosed 19 people that we reported on increased. It really shocks you to think, are you serious? Did you hear what we just said? 19 people died as a result of this drug. Don't do this. I don't care who you are. You're Superman. You're still going to overdose if you do this amount of drug. It's so reckless.
So I think that points to this sort of perverse kind of rationale if there is and sort of the perverse economy of this particular drug, if there is a rash of overdoses in some ways, that source of the drug can see an increase in demand, and it's really alarming. We have a study right now ongoing among patients in our opioid treatment clinic. It's basically, what are your experiences with fentanyl? It turns out that some people really like fentanyl. They like fentanyl because it gives them an incredibly powerful high, but they also, all of them have known a lot of people who've overdosed and died. And so, that begs the question, if you don't have naloxone around, and sometimes naloxone is not even effective for fentanyl because it's so powerful. You need to have multiple administrations of naloxone in order to counteract it. It begs the question, what tools does someone have to protect themselves against an overdose? And so at this point, we're thinking through, things like harm reduction approaches, education for the community that is dealing with this, relative to only using with people, only, perhaps even testing the product or knowing more about what the product is before they engage with it.
So are we seeing cocaine mixed with carfentanil in Tennessee?
We are.
And why is it happening in some parts of the country but not others?
I think that's just the established drug trafficking organizations that are out there, it's just going to be what's available to them. And again, you can look at the particular drugs and what drugs are being abused. For example, we see fentanyl cut into a lot of things. So one of the questions is, why is heroin more popular in one area, such as the Memphis area? It really hasn't. It hasn't fluctuated very much. There's been a steady availability and supply of heroin in Memphis, not so much in the eastern part of the state, where now heroin is backfilling. But the same goes with Oxy 30s are very popular in some regions of the state. Percocets are very popular in the Nashville area. Oxys are very popular in Oak Ridge area. So where we've seen those pill press operations, the type of pill that was being pressed was the popular drug that's in that area. Oak Ridge, if we see a blue Oxy 30 coming in to the crime lab that's a counterfeit, the likelihood it probably came from around that area. So that also gives us the ability to source back. So that's what it's about. It's what's popular or what's available to them at the time.
So there was an interesting study from I think the Ohio Harm Reduction Coalition did this report, but they looked at cocaine that came into the state, and basically they partnered with their equivalent of TBI, and they looked at the cocaine that was coming into the state at the sort of the base level, so the stuff that was smuggled in. And then at each level down, at each interdiction point down the chain, all the way to the street dealer, and this is cocaine, they looked to see how much fentanyl was in each of the different levels. And they found a linear increasing amount of fentanyl all the way down to the street. And so the question was, is this intentional or is it accidental? And the conclusion that they came to was it was accidental because of the very small nature of fentanyl and the processing equipment that is used to grind and mix the different drugs together. Basically, their speculation is it's contamination of the machines or coffee grinder or whatever that is being used to mix up the drugs. So to your question, Tommy would have better understanding of what we're seeing in terms of interdiction in the state, but just at each level down the chain, all the way down to the street dealer, that study indicated that there was an increasing amount of fentanyl. And we're talking about like very small amounts of fentanyl having a significant impact.
If I could, absolutely. It's all about the money. It's dollars and cents about it. So when it's coming in, the primary source or the major source, it's going to be in a bulk amount. So each time it steps down on those layers, typically what's going to happen is there's additional cost that's associated with either the transportation of it, distribution of it, the movement of it, the use of it by the individuals, so they're going to step on it or cut it. And so where he's exactly right, by the time it gets to the street level and you get to a dealer that's dealing in gram or ounce amounts, then that drug has already been stepped on a number of times. If that dealer starts receiving some complaints, or in fear that he may receive complaints and somebody doesn't want to buy from them, that's where they will explore and utilize options to cut it with something else. I've got this carfentanil or urinal fentanyl or something that I can cut it with. He's exactly right. The mechanisms in which we are finding crude is an understatement. They're literally a blender out of Walmart, or that they were Walgreens or wherever they would purchase a small blending object. The types of other adulterants that they're going to put in there is just off the chart. So we're literally seeing drugs that come in that are represented as cocaine or represented as a pill that contain absolutely nothing of the drug it's supposed to be. And we're doing a much better job now, even in our crime labs, of going in there and documenting exactly all of the other drugs that we find in there. And so it is a crazy concoction from anything that they can get their hands on, from aspirin to ibuprofen to Nisotol, vitamin B12, it's across the board. But again, it doesn't matter. Like Doc's talking about, it doesn't matter as long as it got them high. And the narrow, the potency of fentanyl is so powerful in microscopic amounts that it doesn't take very much at all. And so that cross-contamination of the devices, it's sticking in there, it unlodges. We're not talking about 5, 6, 8 grains of something that could be the difference in that substance, or that transfers to that person.
Yeah, think about what a coffee grinder looks like after you grind coffee, right? I mean, it's still got a bunch of coffee in it, and even if you dump it out, and so there have been some harm reduction efforts aimed at dealers, trying to get them to clean their equipment for this reason.
Yeah, so, Tommy, I don't feel like we can talk about drug trends and not talk about meth too. So I thought that the meth crisis was something that we dealt with 12, 15 years ago when we had meth labs springing up in rural areas, but all around, and we had a lot of strategies we implemented and a lot of new laws come in, and I thought we had sort of handled that fairly well. But meth is making a comeback. So where is it coming from, and how is it different than the previous meth crisis?
With a vengeance.
Yes.
We're probably on track to receive more submissions of methamphetamine into our crime lab than any time before. Even at the heyday and the height of our meth epidemic in 2010, where the state of Tennessee had the dubious distinction of being number one in the nation, the meth capital of the United States, with 2,086 meth labs, or about 7.8 labs per day. We did think, and we threw a lot of resources at this thing, and we really went after it. But at the end of the day, just what we're talking about with the cycle and circle of addiction, this one's two-pronged. Again, you squeeze the balloon. If we don't address the addiction issue, addiction's addiction. So we did reduce. We made it much more difficult for them to acquire the precursors. We did stop, and our meth lab seizures have decreased about 86% in our state, which is good. The bad thing is we still have an insatiable appetite for stimulants in our state, and the Mexican drug cartels have a ready supply and the willingness to feed and to fuel that desire for methamphetamine. The other second prong to this one, though, I think is a little bit different, a little bit unique, is that if we look at the history of opioid abuse or epidemics in the United States of America, historically, this is about number 3 for us. And if we'll look what followed each of those opioid epidemics, it's stimulants. So again, this is that wave 4. This is that transition. We are into the phase of illicits, and we are also transitioning into the phase where stimulants are becoming more and more dominant. This is not really nothing new from an historical standpoint. It's just bigger than it's ever been before, and we have a better way of communicating it out there. Meth is here.
That's absolutely right, and thanks for making that point about the waves. I mean, that's exactly what's going on. We're seeing it in our clinic at Overmountain Recovery, for example. Our methadone patients that are coming in, if they're screening positive for illicit drugs, it's methamphetamine, and that's a problematic scenario. There was an interesting paper that was published last year by Ted Cicero and his colleagues from Washington University in St. Louis. They indicated an 82% increase in methamphetamine positives over the past 6 years at such clinics as ours. And then they unpacked why. They did a qualitative assessment thereafter and said, why are you guys engaging with methamphetamine now? And the answer was availability, and they really like to get high. The driver after the wave of opioids could be as simple as going back to this earlier topic of prevention, right? How are we going to help protect our society from the problem of substance use disorder if we're only dealing with the treatment side? We've got to get upstream and fix whatever is going on relative to driving people toward seeking their, trying to fix their pain and their mental and emotional, physical pain with something besides, coping and other kinds of effective strategies.
Normally across Tennessee, we've seen a lot more opioid activity in East Tennessee, and it's sort of less as you move across the state to the west. So how is the most recent statistic showing geography-wise?
Again, going back to some of the reporting, talking about the larger cities versus some of the smaller cities, I think this also goes into one of the questions from earlier about reporting. A lot of the rural communities, those overdoses were going unreported. Now those are more. So when we compare that to the major cities, you've got a couple of things going there with those. Number one, that is the source of supply for the majority of the illicit drugs. That's an easier place, and the price going straight to the major city, the price of the drug is cheaper. Two, just the nature of the drug addiction and the drug abuse and the way that it works, they're going to find a way to get closer to the source. And going to the source means that's where they're going to do the drug as soon as they get it. They're overdosing, they're doing the drugs, they're getting the drugs, and they're overdosing at that location. And that's also where we have the majority of our resources in terms of forensic pathologists and our facilities to analyze those and to determine that it was actually an overdose. But those major cities, I think they get labeled. They probably get a few more, and that's where it's going to be reported. Even if that person traveled in from Kentucky or another state, if they overdosed in Nashville or in Chattanooga, then the stat for the overdose is actually going to be attributed to Chattanooga or that city.
So to your question that you made about to the point that you made rather about we should see more in East Tennessee and sort of moving west. It is true. I mean, we saw more earlier on in northeast Tennessee, and then as we began to increase access to treatment options there, and Suboxone providers and others began to proliferate, our overdose rates in the Northeast are beginning to level off. That is not true moving west. So moving just outside of the 8 or 10 counties in Northeast Tennessee, and then moving west, you're beginning to see growing numbers of overdoses per year. But you also have less access to treatment there.
So we talked a little bit about reporting, Tommy. What changes have we made in reporting, and still today, who's being missed?
We've made a number of changes in terms of the agencies and identifying those agencies that are receiving the information or that are in a position to capture and report. So some of just to name a few, one being the hospitals and the emergency rooms, and then the mechanism in which they do report and who they report the information to. So there's been some legislation, there's been some changes there that now they are required to report those overdoses, and then the time frame in which those overdoses are also reported. Two, there's also some limitations to that because you have forensic pathologists, the forensic centers. We have 5 forensic centers across the state of Tennessee, and they service particular counties or groups of counties in those areas. The way they record an overdose versus the way it may be recorded or reported from a forensic pathologist. So those also, we have not overcome necessarily the hurdles in terms of systems. So we have different systems. The Forensic Center in Knoxville may operate off of a different platform or a different reporting system than Memphis and Nashville, which are on the same system, and then versus Chattanooga. So we're not quite there yet in terms of linking and interfacing all of the systems together, and that's just on the overdose. So there's a lot of moving parts. Law enforcement, for example, is another complete system. EMS is another complete system, and that one will actually go live October. We're all EMS operators, and there are well over 100 different EMS units across the state. But they had their different reporting systems that they reported to, different proprietary or not. So we've got a bunch of moving parts out there, and those moving parts, when you have so many, you really run the risk of we're capturing and they're doing their jobs, but we're just not getting it to a central location where we can look, evaluate, and report all of the information.
And this is a good point. I mean, the data systems don't all speak to each other, and there are efforts at our state level and at other states to begin to merge those systems and to begin to make them speak to one another and for the public's benefit. And so I applaud Tommy and others on the state epidemiology outcomes working group and others that are beginning to make some of those things more available.
Dr. Peck, put this epidemic in perspective to other public health crises that we've had.
Goodness. So a colleague of mine, Randy Wyckoff, our Dean of Public Health at ETSU, said that in his career, HIV and AIDS was the defining epidemic for his cohort of professionals that came through, and others may say, well, it was cigarettes, right, and tobacco control is kind of the defining risk mitigation strategy for that. This is certainly, for my career, the most alarming crisis that I have seen in this country. For reasons of its insidiousness, and also the long duration of opioid use disorder, and the fact that this isn't something you can prevent with a vaccine. It's not something you can cure with one simple treatment. It's something that is a chronic relapsing disease, brain disease, basically. And my colleague Judge Dwayne Sloan says that we have an opioid and mental health fueled addiction and suicide crisis, and that begins to unpack some of the complexity of what's going on. But a lot of this is driven by undertreated and untreated mental health in the first place, and so until we get upstream of this, we're not going to have any significant impact with just treatment and just naloxone, for example. It's often said you can't arrest your way out of this problem. Well, you also can't Narcan your way out of this problem. And we need to get way upstream and start doing really good prevention with younger kids so that they grow up with the resilience to not be affected by this problem long term.
Going to what his point was, the volume of this, it's just so large. I mean, this is huge. You can it's easy to compartmentalize addiction and whatever the flavor of the day, and I hate to use that type of an analogy, but the flavor of the day where it was methamphetamine, where it was this one. The difference, though, yes, the flavor is changed. This is pharmaceuticals. This is opioids. It's just the it's so far-reaching, and the volume of people that are impacted, affected, of all types, and it doesn't discriminate one way or the other, and everybody can be. But it's also the wave where you're going to transition. You're going to have to go through this, and we're going to go through this, and there's going to be the intended consequences and then the unintended consequences. But what you have to do is you have to keep your foot on the gas, and we have to keep moving forward, understanding that we're going to have some hiccups on the backside of this. The buprenorphine, for example. We're going from diverted pharmaceuticals. We've slowed that pace. We're transitioning in. It's going to the illicit drug flow. We know the illicits. We're gaining on that one. I think that's probably an area we still need. We're going to have a lot of work. But it's going to be a problem a long time. Doc is correct. We've got to go upstream as far as we can to prevent the addiction before we start getting in. And we've got to stop the cycle of addiction that's occurring within these, because it doesn't matter. If we don't stop that cycle of addiction, then all we're going to do is repeat it. And it's going to be a different flavor. It's going to be something else, and we'll repeat it.
There's the provider side, right? Sometimes those restrictions are seen as being constraints on medication-assisted treatment practices, and those can be significant disincentives to getting involved in addiction medicine, and really we need more access for high-quality providers, or by high-quality providers, and some of the things that we need to examine in this is co-prescribing of benzodiazepines and minimizing that to the extent possible, making sure that the providers are accepting all forms of insurance, making sure that they have good counselors and well-trained counselors on site, and we organize the system in a way that the incentives to engage physicians and other prescribers on the provider side is really good. And one more point that I would like to make about this is we also have to educate pharmacies about addiction medicine. Because the interface of the patient with the pharmacist is often very challenging for the patient, and it's loaded with stigma, and there's all kinds of stigma associated with the condition anyway. But there are a number of pharmacies that just simply won't dispense buprenorphine, and they won't give it out to their patients, and so we have to begin addressing that as well. And it's the focus of some of our research at ETSU.
Let's talk about that a little bit. So what we're talking about is medically assisted treatment, and some of the drugs that are used for that could be diverted and used in an inappropriate way. Is that kind of what we're seeing a little bit around the state?
Yes.
Okay.
And less so with methadone, because methadone, the constraints on methadone are very, very high. To actually start a methadone clinic, you have to have all these diversion controls in place. But I think it's very common to see diverted buprenorphine on the street at this point. Some harm reduction folks would say overdoses related to buprenorphine alone are unlikely, then that's okay. But honestly, very few people are single drug only overdoses. It's increasingly common to have buprenorphine in an overdose toxicology report because it's being used with other substances.
Okay, so one thing that the overdose are 1,837 overdoses in Tennessee in 2018. One number that's not captured in that are suicides by people who have an addiction issue. Is that a trend that we're seeing?
This is an extremely important topic. Untreated mental health, and that's partially driving the opioid problem in the first place. But then when people are in the throes of addiction, as one of my dearest friends was when he took his own life, it's one of the situations where we need to almost lower the threshold of access to care so that they can begin getting good counseling and getting good the proper type of treatment at that time. It's just so challenging, though, to parse out the reasons for an overdose, because often they could be suicide related, they could be someone's desperate and they kind of don't care about what's going to happen to them in the future. So I think that it's a challenging question because you can't know for sure what the intention of a suicide is, if there's no note or something like that. But I think that there is a significant amount of what's called suicide misclassification in the overdose, in that larger overdose group.
So how does meth today differ from meth of 10 years ago?
The methods in which, how it's getting into the United States, the amounts, the volumes of it, it's a synthetic drug. So it can be mass produced. And where those chemicals are not controlled, it can be mass produced, which it is. And then, unfortunately, that predominantly happens to be Mexico. So we've got a very powerful drug that's very cheap. The cost that we're paying, that we're seeing it on the streets, is very cheap. So you got a cheap drug that is very powerful, very good quality, unfortunately.
And is it being cut with other drugs as well?
We do. The crystal meth is a little bit different, but it's easy. There's, in terms of a potency, from even if it's what would be called or characterized as a dirty meth versus a crystal meth, the crystals are obviously what they are seeking. They think that that's going to be much more powerful, much more potent. It's a better form of methamphetamine. It's just another process. I can take the same high quality methamphetamine and take it through another process to crystallize it and make it happen. So in one sense, looking at it, if it is crystallized, we have a less tendency to see that it's going to be adulterated with something like fentanyl. It's not to say that it can't be. If it's more in a powdered form, dingy brown, white, or whatever, it can be pink. You can add any color to it. Those are obviously the ability to adulterate it with fentanyl or use it is much higher. It's not uncommon, though, when we're talking about polysubstance abusers, that is just the way. And again, that's not something that's actually rare. When I was in the throes of in the meth fights years ago, you show me somebody that was addicted to methamphetamine, I'd also show you somebody that's addicted to benzodiazepines. They were doing Xanax, and again, it was to counteract the side effects of that drug. So we would also, even years ago, it wasn't as prevalent as it is today, but we would see the other common polysubstance abuse would be methamphetamine or cocaine with an opiate. They like the effects of one, and they want the effects to counteract some of the side effects of the other drugs. So it's not uncommon to see more and more of those. Many folks that we have spoken to, Doc may comment to that more, that they may come in and they see that meth is the only thing that helps me. I can't transition to another type of drug off of opioids. If I don't have heroin, I'm going to get sick. The only thing that I can do that I will not get sick would be methamphetamine.
So where do you think Tennessee will be a year from now?
I was really hoping to see the 2018 numbers kind of plateau. The good thing is the rate of increase. I am encouraged by the low rate of increase as opposed to or compared to other years prior to. So I'm encouraged, and I'm going to go back and say it again. I'm hoping that we've reached that plateau. We're going to turn the page, and we're going to go on the other side of this and start decreasing that. We definitely see the decreases on prescribed opioids. The decline of those prescribed opioids, the amount of those opioids also indicated coming into our crime lab from law enforcement seizures and law enforcement incidents have declined. So all of the indicators there are very good and very consistent. And then looking into the future of this, it's come up a couple of times talking about mental health. We need to use all of these newly gained partners from all of the various disciplines and take all of this information that we are learning through hard knocks and look into the future to what may be the next issue that's coming down and address this mental health. We don't know anything about cannabis. If we don't know anything about marijuana, what we do know, yes, it's a gateway drug. I know for a fact. And those who did try that, not only were more likely to try other drugs, but the amounts of the other drugs that they tried were greater.
Gentlemen, thank you for joining us today.
Well, thank you very much for the opportunity.
Thank you very much for having us.